Hey, this is Dr. David Sterling. I'm a plastic surgeon in Little Rock, Arkansas. And today we're going through our vlog between myself and my co plastic surgeon in Dallas, Texas.
Hi, my name is Shikhar Tomur, and I'm a plastic surgeon in Dallas, Texas, and I'm excited to talk to Dr. Sterling, a really close friend and colleague, about different things in plastic surgery.
So, what do you want to talk about?
This is a good one. Awake surgeries. Um, I think awake surgery is really interesting, and for me personally, it's been a great start to my practice because a lot of patients that I see, a barrier entry is anesthesia. And so if I eliminate that and then they feel comfortable with me and they know that they'll be awake this entire time, they feel way more confident. And then from a practice building standpoint, I talk to them throughout the entire procedure. And then after they're done with it, they're like, oh my God, you took care of me. You were so nice. You explained everything. That's where I think dentists are way more successful because they have way more patient interaction than we do. We only have our consultation, our preoperative appointment, and then a postoperative appointment, but they have no idea the 5 or 6 hour procedure that we did in between, right? And that's where I think plastic surgeons run into issues is that they don't describe everything that they're going to do in the OR and post-operatively, and that's where this disconnect happens. But I think awake surgery, typically, I might go on a limb, but I think your patients are actually happier almost in awake surgeries than they are not under general anesthesia and things that they're unconscious for.
Yeah, I think that'd be cool. Cool place to start. I do, uh, so we're talking about awake surgery or the different types of modalities you can use for surgery or to do plastic surgery. And for both of us, I think we're both pretty well trained in doing obviously in the operating room or doing something where a patient is awake but we're using local anesthetic, or we're doing oral medications to help calm them down or take away some pain or alleviate some of the discomfort. And in some cases too, you can do awake surgery with like IV medications too. It kind of depends on your setup. But essentially, I guess the differentiation is you're awake for it or conscious to some degree for the procedure versus you're not. And I think talking to a lot of patients and talking to staff too, when I tell them about what I do, they're usually, oftentimes they can be kind of surprised at the fact that we can do things where patients can be conscious or semi-conscious for a major procedure. Usually it's facial stuff. I don't know about you, we can talk about it too, but for the most part, I feel the most comfortable doing awake surgery on the face just because it's so easily anesthetized, and that means you put local anesthetic in, like lidocaine, novocaine, something like that, to numb up and block the area so they don't feel it. And so that's some things like blepharoplasties, some kinds of brow lifts for me. I have done facelifts awake, although for me, primarily, I do that in the operating room under general anesthesia. Lip lifts, I do that awake. Buccal fat removal. So just in general, face related stuff. What about you? What do you do?
I totally agree. I think most patients would opt to do everything under general anesthesia, but I think as people are becoming more comfortable, especially with their surgeon and the environment that they're going to be in, they feel comfortable doing awake procedures. I typically would say no one has surgery for breast augmentation completely awake or an abdominoplasty or anything that's more invasive. I think those areas are, like you said, way more difficult to make sure that you're comfortable during the actual procedure itself. And so those are going to be more tailored to having a procedure under general anesthesia at the end of the day. Um, but yeah, I think that may end up becoming a more sought after procedure or awake facelifts. I think a lot of women are getting facelifts younger, and even men are having facelifts younger. And I think there is definitely a push of less is more. So less general anesthesia, less exogenous medications, all these other things that can affect you. I feel a similar procedure that I did a breast augmentation, and she was fine from a breast standpoint, but she was just feeling nauseous from an anesthetic standpoint. And so, if you can eliminate those um, negative portions of a general anesthesia, then I think that's a lot more beneficial to a patient for recovery.
Hmm. I think it's important too to say like where the settings are for these, because for me I do a lot of awake surgery in my procedure room in my office, but I still have the option for bigger surgeries to go to my surgery center where we can do IV anesthetics. So you're not going fully under, but they use stronger medications to decrease the levels of consciousness or to make you more sleepy and to make it a much more tolerable, but without those kind of deleterious effects of undergoing general anesthesia where you're fully asleep and maybe paralyzed too for the operation. So it can be potentially in a procedure room. It could also potentially be in an operating room where you have access to CRNAs, anesthesiologists, full blown anesthesia, but you can still be awake for it. And the benefit of that too is that it, for me, the preference is operating in a surgery center just because I have all the best equipment there. I have really good stuff in my procedure room as well too, but a lot of my equipment is just the newest and greatest stuff is in the operating room versus the procedure room, and that can vary based on practice. You can obviously get stuff for your procedure room too to make it almost equivalent to an operating room. And there's kind of at some point it blurs the line between what's what is one versus the other. There are legal and compliance related things that's really something that we as plastic surgeons deal with, and patients don't have to worry too much about it. I mean, they should be aware that wherever they're going is a licensed facility, etc. But the nuances of what a full-blown operating theater is versus a procedure room, it does start to blur a little bit in terms of what you can do there and the equipment that you can have too.
This is a good question that I get is what what qualities in a patient would make them a candidate for awake surgery versus not a candidate for awake surgery? Do you have do you have any criteria that you use?
Easy criteria. So the first one I already said is it a place in the body that I will do awake surgery on? Like if someone comes to me just for me personally and they want a tummy tuck done under not going under to sleep or not going under general anesthesia, that's just not something I do. So easy criteria gone. The second one is someone who can tolerate it. I have plenty of people who are like they'll freak out at a needle, or they that you tell the easy test is you talk to them about it and then they're like, "Oh, absolutely not, put me as far asleep as possible," and that's a good indication. I'm not going to sell you, be like, no, no, you'll be fine, everything will be okay. There might be reasons to do one versus the other, but for me, it's like, do I do it, and is the patient comfortable doing that? And if it's like, again, I look at the case too. If it's a very difficult revision facelift, then in that instance, I might say, I really just think I will do a better job in the operating room with having versus you having you awake for this. And I just reason through it with the patient. Whether they accept it or not, that's totally fine. It's up to them. It's an elective surgery, but that's kind of how I go about it. So I try to figure out what the case is like and what I can reasonably accomplish, if I can accomplish what they want, and give them what their goals are for the operation, and can I deliver my goals for the operation too.
I think we're touching on such an important topic is I almost feel in my consultations, and this is just because of training and getting to work with a lot of different physicians, but I feel like younger physicians overall are having way more tailored approaches to patient care than in the past, where you saw a surgeon and they did this procedure and that's how they did it, and then that's what you're going to get. I almost feel, which great is, I have four different ways of doing this procedure, and I can tailor it exactly which way a patient's going to feel most comfortable. And if anything, it makes my consultations a little bit more complex because it takes more time to really delve deep into realistically their priorities. But I think overall, patients are way happier. And then I have not had the situation where after the fact they're like, oh, I wish I did this or did that. They almost am just like, I had a patient that felt like, oh, I'm really happy with how this turned out because I know if I did the other surgery that we talked about before, this would have been the complications of XYZ. And it's like, wow, you made the decision or that decision as well as I did. So and I feel like I learned it from you. There's always an aspect of buyer's remorse, right? You buy, you get a surgery, you spend so much money on it, you have the surgery done, and then you're kind of always wondering, is this the right thing that I should have bought? But if you can really like tailor it to a patient, understand what their goals are, understand how they can be comfortable, if this is a no brainer of doing it under local versus, oh, this is actually going to make you feel really uncomfortable, then it's like this is not worth it at all. Um, and I think you have to take the time to really peel back those layers on every patient to really make them happy.
Yeah, I think I totally agree with that. So having patient invested in their care more, and like, there are two things. One, an example from my practice was not too long ago. I was placing a chin implant, which I do not infrequently for people who do like get a rhinoplasty or might have a facelift or neck liposuction or something. So you're affecting usually the profile of the face. Um, but this patient was really interested in my approach, so going through the mouth intraoral versus under the chin. And I'm pretty comfortable doing them both, but it was interesting having this patient kind of talk to me about it, uh, because otherwise I would have gone with my default approach, which is under the chin. Of course, that's a visible scar. There might be benefits from a surgical perspective and a surgeon perspective, but listening to the patient, I knew they would have regretted, or they could have had that buyer's remorse they were talking about much more significantly if it's like it looked great, it was awesome, super happy, but then all of a sudden, but they had that scar. They're gonna have that forever, and that might be really what the hang up was. And the other thing with the easy one too is, and we get this all the time, patients and breast implants. So how their level of involvement with determining the size, the shape, the type of implant that you use. I've seen a lot of patients. I actually have a really large practice of women who have had implants for 20, 30, 40, 50 plus years. And when I delve into the history of their implants and when we talk about it, a lot of the times they don't know what the volumes are. They don't know. They usually know if it's saline or silicone, but sometimes they're not sure. They're not sure if it's below the breast gland or partially below the muscle. They don't know the manufacturer or anything like that. So it's very interesting in those situations. They got it in some cases because the surgeon, that's what they told them they were going to do, or maybe their partner at the time was like, this is what I want her to get. But for me, we spent a long time talking about volume, and I make it very clear we do sizing. I do sizing where they put the sizers in the bra. It's not a perfect system, but realistically, there's no perfect system. I do the tissue based method, so it's like this is how big your chest wall is. This is what I can realistically accommodate for you, and then we come to some determination from that involves what they're expecting and want and what I can deliver. And then I finalize that with, and by the way, just so we're clear, we're talking about a range, from this to this. But there's always a range because maybe tissue's a little bit tighter than you think, or maybe the look wasn't exactly what you thought with this one profile or this one volume or shape. And so you might have to make an adjustment, but you've agreed upon it beforehand. So I find that leads, at least in my hands, to much more satisfied patients.
Okay, well, that was a great conversation, Dr. David Sterling from Arkansas. We will 100% be doing this again, and I look forward to our next conversation.
Yeah, no, that was a great talk. Thanks, Shikhar, for joining me, for making this video. And yeah, I look forward to talking about more stuff and then hopefully educating our patients on things that we do in our practice.